Good morning or good afternoon to every participant and welcome to this first online surgical lecture hosted by Delacroix-Chevalier. Thank you very much to each of you for attending this second session. You are at the right place to watch renowned cardiac surgeons providing more details about a very interesting topic, minimal access aortic surgery. This session will be divided in two parts. The first 30 minutes will be dedicated to isolated aortic valve surgery through a right-anterior mini-thoracotomy approach. The second half hour will address complex aortic surgery through a mini-sternotomy approach. At the end of each part, the surgeons will answer your questions. Please ask your questions using the live chat available on the right side of your screen. Before we start, I'm glad to introduce the two surgeons who are going to speak today. Our main speaker is Professor Tristan Yan from Sydney, Australia. Professor Tristan Yan is the head of robotic and minimally invasive cardiothoracic surgery program at the Royal Prince Alfred Hospital based in Sydney. He is also the head of the thoracic surgery at the O'Brien Lifehouse Cancer Centre in Sydney and a visiting professor of cardiac surgery at St. Bart's Heart Centre in London, UK. He studied in the USA, in England, Scotland, and then in Germany. He has authored or co-authored more than 250 papers, and he is also the editor-in-chief of the Annals of Cardiothoracic Surgery journal. He is recognized for his specialty procedure, minimal access aortic surgery, which we will hear more about in his lectures today. In the year 2017, the Delacroix-Chevalier company in Paris launched a full set of minimal access aortic surgery instruments designed jointly with Professor Yan. Good morning, Professor Yan. I know it's early in the morning in Sydney, 4 a.m., so a special thank you for being with us so early. We really appreciate your dedication.
Morning.
Our second host is Professor Martin Misfeld from Leipzig, Germany. He will lead the questions and answers sessions. Professor Misfeld is a senior consultant and professor of cardiac surgery. MD in 1996, PhD in 2004. He studied in Germany and then in London. Today, he is a leading senior consultant in minimally invasive valve surgery in Leipzig Heart Center since 2009. He is also a visiting medical officer, Department of Cardiothoracic Surgery at the Royal Prince Alfred Hospital in Sydney. He has authored or co-authored more than 260 papers and 20 book chapters, and he is a reviewer for leading cardiovascular journals like ACTS or EJCTS. His main surgical areas of interest are minimally invasive cardiac surgery, valve reconstruction and preserving trade techniques, MACE procedures, and complex aortic cases. Good evening, Professor Misfeld, and thank you as well very much for being with us today.
Good evening.
So it's now time to start. Wishing you all a nice session, and Professor Yan, I let you take the lead and share your first presentation. Thank you.
Thank you, Thibault. Good morning, Martin. The first presentation, I will focus on the aortic valve replacement procedure via a right anterior mini-thoracotomy approach. And then later on, we'll touch on the Mini-Sternotomy approach for complex proximal aortic aneurysmal repair. Okay. I'm a cardiothoracic consultant based in Sydney, Australia. Thank you for having me here. Here's my disclosures. When we talk about mini-access aortic valve replacement operations, broadly speaking, we are mainly looking at two main different approaches: the Mini-Sternotomy approach and also the right anterior mini-thoracotomy approach with or without assistance of an endoscope. And also we are looking at two valve types: the conventional surgical valves, whether it's tissue valve or mechanical valve, versus a rapid deployment valve. The main aim to perform a minimally invasive aortic valve replacement is really for our patients to have a surgical operation without the collateral damage associated with the traditional approach. But also as surgeons, we try to conduct an operation that is simple and reproducible, and more importantly, and make it enjoyable. I think that is very important as well. Here are some basic points I would like to make. I do think the Mini-Sternotomy and Mini-Thoracotomy approaches are both valid operations for isolated aortic valve replacement. As cardiac surgeons, we should be familiar with both and use them interchangeably according to the patient profile. And also, I think the Mini-Sternotomy is a versatile technique, not only for aortic valve replacement, but also for more complex operations such as aortic root, ascending aorta, proximal arch, and sometimes total arch replacement. So it is important to bear in mind we don't have only one approach. We have multiple different techniques that we can use for aortic valve replacement. I know there are surgeons using a transaxillary and also a total endoscopic approach, but just bear in mind we need to be versatile when we're looking at aortic valve replacement. So why Delacroix-Chevalier? Well, the project really started more than 7 years ago because they have a long-standing tradition of finance craftsmanship. We also have a very dedicated research and development team, and together we have a shared vision that is really to produce a set of surgical instruments and dedicated for mini-access aortic surgery. It is a subspecialty procedure, and I think we should have the instruments specific for aortic surgery rather than using mini-access mitral surgical instruments or conventional instruments to conduct these operations, to make the operation easier for the surgeons and safer for our patients. The instruments are specifically designed to make them simple and stable, have got a low profile to facilitate the operations. So which we'll see more of these instruments throughout the presentations. With the use of these instruments, you can perform a aortic valve replacement via a right anterior mini-thoracotomy down to 3 centimeter surgical incision. Just one slide that I will touch on the mini-sternotomy approach. I do think the mini-sternotomy or upper hemisternotomy approach is very versatile technique. You can basically perform all sorts of proximal aortic procedures via this 5 centimeter access incision, relying on central arterial cannulation and femoral venous cannulation. The key, I think, is a left-sided sternodivision rather than a right-sided sternodivision to expose the aortic root and also the junction between the aorta and the pulmonary artery. We rely on antegrade custodial cardioplasia, and I do think it is a very versatile approach, provide excellent safety profile, but you do have to divide the sternum. But that's okay because we're all cardiac surgeons and sternodivision is not a major technical issue. But this approach does offer surgeons much more versatility when we talk about complex proximal aortic operations. The right anterior mini-thoracotomy, in my practice, is only reserved for isolated aortic valve replacement. I don't do root ascending or proximal arch operations via these 3 to 5 centimeter incisions. I rely on femoral cannulation. You can cannulate the distal ascending aorta via the right anterior mini-thoracotomy, but I think for safety reasons, my preference is femoral cannulation. The advantage is there is no sternodivision, but as a result of femoral cannulation, you do have to take into account the potential complications and issues associated with the retrograde perfusion, such as embolization. With the use of endoscope, you can also reduce the main access incision down to 3 centimeters from a 5 centimeter incision. Because the endoscope provides you the additional vision down to the aortic annulus, especially around the right coronary annulus. Once again, relying on femoral cannulation, the issue of peripheral cannulation must be considered. So how do we do that? Well, with this 3 centimeter access incision, and you will expose the mid ascending aorta, especially on the left side, the lateral side. We use a soft tissue retractor, okay? And in patients with undergoing a right anterior mini-thoracotomy, preferentially, I look for the patients with elongated ascending aorta rather than very short, stubby ascending aorta, so that we have room for cross-clamp, room for cardioplegia, and also aortotomy incision and also to make the closure of aortotomy much safer. So if patients have a longer ascending aorta, that it would be my preference. But you have to be very careful, because in patients with aortic annulus more deviated towards the left side of the sternum or tucked underneath the sternal plate, it can be very difficult to see what you want to see sometimes. Be careful with calcified bicuspid aortic valve down to the calcification may go down to aortomitral valve curtain. To be mindful that when you're doing this operation via 3 centimeter access, you're doing the operation by yourself, because your surgical assistant on the other side of the table can sometimes difficult to see, even with the endoscope. Patients with a small aortic root, or patients you're worried about the obstruction of the coronary ostia, you need to be very careful of using the right anterior thoracotomy. So by and large, for patients who have a straightforward aortic valve replacement, okay, using a right anterior mini-thoracotomy, I think is a very safe approach, but you need to be a little bit more selective. So the incision should be right at the level or land down to the right superior pulmonary vein, okay? Through this main access incision, once the retractor is put in place, you should be able to see the ascending aorta, and imagine the access from the ascending aorta to the aortic root and to the aortic annulus in one straight line. It really doesn't matter how far the aortic annulus is. You can use the endoscope to look down through the main incision or through a separate incision down to the aortic annulus once the heart is arrested and the aorta is open. I routinely use 3 pericardial retraction sutures on the right side, the surgeon side, and really hitch up the skin to the hitch up the pericardium to the skin level, and that will rotate the ascending aorta slightly towards yourself. No pericardial sutures usually is required on the left side. However, there are 2 potential blind spots, and I think people need to be mindful of. That is, number 1, the right coronary annulus, especially if the aorta is very close to the sternum and tucked right under the sternal plate. And once you open up and decalcify, sometimes it's very difficult to see the right coronary annulus because it's tucked under, and it can be difficult to place the sutures, okay, around that area. So in those cases, you know, for patients with aortic annulus very far to the left or very close to the sternum, you need to be mindful of this, the blind spot. The other blind spot is the inner curvature of the ascending aorta. Therefore, it is important when you perform a aortotomy, don't go too far towards the left side around the inner curvature of the aorta, because sometimes you can't close it properly through a 3 or 4 centimeter access incision. So the aortotomy, you have to think about, if I cut it that way, or can I close it safely? It's all about safety. And be mindful of these 2 potential blind spots. Otherwise, the operation will be quite straightforward. Now, We use a adjustable aortic retractor. Has got a textured surface. Now you can use the back of forceps. Your assistants can hold the ascending aorta and also the superior pulmonary vein. Also the SVC towards themselves. But the back of the forceps can, the structures can slip away. So using this adjustable aortic retractor, you can effectively expose the right superior pulmonary vein and use a single shaft needle holder and place this purse string for the vent. And this is the adjustable scalpel blade holder. And according to the depth you want, you can make it longer and shorter, and make a stab incision in the right superior pulmonary vein and insert the vent you routinely use and to empty out the heart. So I think it is very clean and easy to do this. There's not much of a stress and struggle, even through a small incision. So as you can see, these instruments are quite simple, but they are very effective with these features designed in mind. I use a separate stab incision lateral to the main incision, about 5 centimeters laterally, and I insert a chipwood cross clamp through the transverse sinus. It is important you can mobilize the ascending aorta from the back of the right pulmonary artery posteriorly, and create a little space so you can pass your cross clamp more catheter direction. Or alternatively, you can insert a cross clamp through the transverse sinus. Just make sure that you don't catch the left atrial appendage around the back, and move the cross clamp more towards the head, or gently pull the ascending aorta downwards to allow you to have the space to perform an effective and safe transverse aortotomy, or slightly at a tangential direction. It's all about the safety. Now, through the main access incision, often you will see the aortic annulus and aortic root very effectively. But sometimes, if you can't see the annulus, the whole annulus, with traction sutures, through the main incision, I think it would be very useful to use an endoscope to effectively expose the aortic annulus all around to facilitate the placement of the sutures. Even the annulus is far away, sometimes you can use this approach using an endoscope. The endoscope can be parked or can be positioned through the main access incision, looking down the barrel like a straight shot, or you can make a separate 5mm port lateral to the main incision. It really depends on aortic annulus, and every patient is different. The body shape is different. I think you just need to be versatile, but the key is to position the endoscope at such an angle so you have a straight shot looking down the barrel of the ascending aorta, and you can see the placement of every suture either through the main incision or with the assistance of the endoscope. I don't really care too much about, okay, it has to be entirely endoscopic or direct vision, because I think you sometimes need all angles to see the aortic annulus. So try to use the endoscope. I do think that will help with the exposure and placement of the sutures. Now, I routinely use a conventional valve and use a core knot device to secure the valve. And I do think there's a very secure way of performing aortic valve replacement. You can use rapid deployment valve. People use a rapid deployment valve through a small incision, but I like the 100% reliability of a conventional valve. There's no chance of a parabolic leak. At least you minimize it as much as possible. And also be careful with the coronary ostia position, because sometimes when, especially patients with bicuspid aortic valve, where the rise of the position of the coronary ostia can be very low down, and the root can be quite small. You need to be careful of make sure there is no obstruction with the struts of the tissue valve around you know, the coronary ostia. It's all about the safety again. Now, we also designed this finger extension knot pusher. I mean, it looks very simple, but I think it's very effective for performing an aortic valve replacement. And you don't need to have two people, you and your assistant, to tie knots using the long shafted knot pusher that we use for mini mitral procedure. And all you have is extension of your digit by one phalanx. In the index finger, along the index finger, and that is enough to reach the right superior pulmonary vein vent insertion side. And even sometimes with patients with very deep chest, you can just tie that knot by yourself and using you know, your routine freehand tie to slide the knot down. There's a little slit, a little groove at the tip of this knot pusher, and that will secure the knot and all the way down there. That is enough, and we do think this is a very simple gadget that will really help the conduct of the operation, and a lot of surgeons found this very useful. We do run a minimally invasive cardiothoracic surgical program in Sydney, and due to COVID this year, the cadaver course has been postponed to next year. But feel free to check this out as well. So that will conclude my first presentation on right anterior mini-thoracotomy for aortic valve replacement. And thank you for your focused attention.
Tristan, thank you very much. It was a great talk, and thank you for sharing with us your key steps, how you perform this right anterior thoracotomy, and also thank you for sharing and demonstrating the benefits of this special design instrument, which really makes this approach much easier. It is important to mention that overall around 540 colleagues registered for this meeting, and the far majority cardiac surgeons, and they were asked questions before, and just to let you know that around 40% perform isolated aortic valve procedures through partial upper sternotomy, and around 10% through this approach you just demonstrated. So let's start with some questions starting from patient selection. And you mentioned that small aortic annuli and severe, heavily calcified aortic roots and valves, especially bicuspid valves, are in your experience some sort of contraindication for this approach. So obviously preoperative echo is important. What else with regard to preoperative imaging do you need before you perform this surgery?
Thanks, Martin. I think it's vital to nowadays to perform CT aortogram, or you can use the TAVI protocol to assess the aortic root anatomy and also the coronary ostia positions these days. You don't want to be caught by surprise and through a small access incision, and you have difficulty in position the valve, and especially for those patients who have very low coronary ostia. Anything that is complex that you can't fix through a right anterior thoracotomy is not a simple aortic valve replacement. I would perform the valve replacement via a Mini-Sternotomy approach, because it's much more versatile and you can utilize your system, and also it is just much safer approach. And out there by yourself via a small right anterior mini-thoracotomy, it can become a procedure of a single surgeon operation. So you have to be selective and think about, can I cross-clamp this aorta? Can I make aortotomy effectively? Can I close that aortotomy? And can I decalcify by myself? And also, once the decalcification is performed, can I remove all the calcium debris? Though these are important, information and considerations a surgeon have to make at the beginning of the case, I would recommend to perform a right anterior thoracotomy at least to start with simple aortic valve replacement cases. The procedure is simple, but the patient selection can be quite tricky. So I wouldn't necessarily select very extensive calcification around the aortic annulus and going down aortic mitral valve curtain, those cases first. I wouldn't also, select the patients who have very short, as I mentioned before, very short ascending aorta. Anything complex, try some mini-sternotomy approach that you're familiar with, or full sternotomy as a matter of fact, but straightforward aortic valve replacement with calcifications mainly on the leaflets, or patients with aortic regurgitation, for example. These would be excellent cases to use a right anterior mini-thoracotomy approach, I would say.
Okay, what about severe obesity? Because this patient may benefit most for sparing the sternum. Are there any contraindications to perform RET in heavily or severely obese patients?
Yeah, well, there are potential benefits, but also I have to say it won't be an easy operation. I know surgeons talk about the bigger the operation, inside is the same via a small incision. There is a lot of epicardial fat you have to remove, mediastinal fat pad, and the aorta tends to be shorter, can be a little bit more fatty. I have to say that you are not prepared for a simple and straightforward approach via this. And you have to make that judgment. If you're up to the challenge, by all means. But the first principle of doing any operations, these are all useful tools in front of you. And try to make your life simple and easy. That would be my advice, because ultimately you have to make sure the operation is safe. So I'm quite selective in terms of which approach. For patients with high BMI, gross obesity, and I would be very careful and I'd be mindful of doing this via right anterior mini-thoracotomy through a small incision. You might be able to do it with a bigger incision, but I think that will defeat the purpose.
Excuse me for looking to the left, but more questions are coming in, and the next questions are regarding your access to. So you always go into the second intercostal space, and how do you deal with the right INA?
Yeah, most often is the second intercostal space, sometimes the third intercostal space. But I always expose the second intercostal space to have a look where is the right superior pulmonary vein. That would be my determinant for the position of the main incision. I divide the right internal memory artery and vein routinely with a double clip, and then divide in the middle. Some surgeons don't make the incision a bit more lateral, that's fine. But I find that if you stretch the main incision with a retractor, sometimes inadvertently, the internal memory artery can be bruised and can be torn. If bleeding happens, the memory arteries will retract underneath the ribs, and it's very hard to chase them. So chase the artery and the vein. So I routinely divide the right internal memory vessels, and if at that level you think that you're not low enough, you can also divide the costal cartilage of the rib inferiorly to provide better access.
So next question is coming in regarding right anterior thoracotomy versus TAVR. So do the criteria for selecting patient TAVR or this conventional aortic valve replacement through this approach is the same like for all other approaches? So in other words, would you perform this approach also in elderly, maybe a little bit more risky patients, where others probably would perform a TAVR?
I don't think that the right anterior thoracotomy versus TAVI is even in my book as a way of deciding which approach I use. I think the TAVI versus a surgical valve, and we go through the routine selection criteria for patients, either a surgical valve or TAVI. And I think more likely for patients who are older, more arthromatous disease than calcified aortic valve, I would use less of a right anterior mini-thoracotomy, mainly because the risk of retrograde embolization and stroke. for those patients with a bit of a calcification in the descending and abdominal aorta and aortic arch, especially porcine aorta, I think that will more preferentially do approach with antegrade perfusion via the distal ascending aorta. So older patients, I think in my practice, less likely to have a right anterior mini-thoracotomy approach. They're more likely to have this aortic surgical valve replaced by a mini-sternotomy approach.
And what is your view on rapid deployment valves and sutureless valves? Do you use them in your practice?
Yeah, I use them. I prefer using the conventional valve because I don't think it really takes much more time. And also I think gives me 100% reliability and 100% security of anchoring the valve, the position of the valve in such a place that you won't have a paravalvular leak, especially with the core knot. You don't have to worry about tying knots all the way down in a deep dark hole using the core knot. It's very simple, and also there is much less chance of paravalvular leak with the conventional valve. So that would be my preference. There are selected cases use a rapid deployment valve, but I think that it represents maybe less than 3 to 5% of my practice these days. I started using a rapid deployment valve, but I backed off from it just because of the very small risk of paravalvular leak.
Okay. Other questions are coming up, and they are regarding your the situations where you have to be forced to convert to full sternotomy. And I think it's probably the most important part of it is not to convert too late. So what do you think are potential risks that forced you, or maybe have to force you to convert to full sternotomy?
Yeah, well, touch wood, these situations are rare if you select the patients well. And don't be afraid to convert, and don't be concerned about doing it through a sternotomy approach. And if you convert, don't convert to a mini-sternotomy, convert to a full sternotomy. And that is, there is a mental barrier when we're first starting off. Okay, I have to do it this way, and if I can't achieve this, is a sign of a surgical failure and the bad results. But don't think that along that way, because there is a patient in front of us, and if you have difficulties in accessing the aortic valve with or without endoscope, there is something not quite right you're concerned about. Just do it through the conventional approach. And the aortic valve replacement procedure should be very safe. And I don't think that you're achieving anything at all by struggling through a small incision if you can't see and can't close the aorta properly. So, you know, I think that mental barrier is something we need to get across, and it can be as difficult sometimes, and maybe more difficult than the surgical procedure itself.
Okay, excellent. Another question regarding the ventilation management. So I assume you have a double lumen tube in every patient, and and some surgeons use the left lung to shift the aorta towards the right side by applying some sort of PEEP during the procedure. What is your experience with that?
I don't get myself into a situation and use the left lung to push the mediastinum across, because those patients I wouldn't even do via. I mean, I said touched on before. Try to select those cases that you can just do this operation simple and straightforward, and make sure the aortic aneurysm position is easy for you to access and easy to close, easy to de-air, and easy to do the valve replacement. And think about the whole process. Can I access the aortic valve effectively through this operation in this particular patient? I use double lumen tube, but also at the same time, there are surgeons that don't use double lumen tube and for effective exposure because you only need a short period of time to expose the ascending aorta, and then you can go on to cardiopulmonary bypass as well. So the practice is quite variable and really depends on your preference. Yeah.
Excellent. Maybe one final question before we go on with the next talk, Tristan. Do you have a special pain management in your patient?
Yeah, I use a paravertebral catheter, which is a 16 French catheter. It's difficult to park this paravertebral catheter, even with the endoscope, all the way around to the back. Okay, so I will insert this catheter lateral to the main incision, to the stab incision where the cross clamp is, and then tunnel it along the extrapleural plane. As far back as possible towards the angle of the rib as possible, and infiltrate quite a large volume of analgesia. And that's how we do all the minimally invasive thoracic operations. Use a paravertebral catheter. You may not be able to pass the tip of the catheter all the way around to the back, but along the same intercostal space, and especially along the main incision, I think can be quite helpful.
Excellent. Thank you very much, Tristan. So I think we go on with the next presentation.
So the second talk will focus on mini-axis aortic replacement, aortic aneurysmal surgery. And it's really a presentation I've made based on our first 150 cases. This is my disclosure slide. Patient selection is the key. So what have we learned from patient selection? Well, I think if you have a patient with aortic aneurysm, proximal aortic aneurysms, such as the aneurysm of the aortic root, ascending aorta, and a proximal arch. I know routinely people tend to do this via a full sternotomy approach. But just think about it just for a second before you proceed, because there is a chance. There is quite a good, there are good cases where you can select those patients for consideration of mini-axis approach. In my practice, it's pretty much all elective aneurysmal repair are done via a mini-sternotomy approach. But that is developed over time. There are absolute contraindications, and I don't do anything minimally invasive for patients who have aortic dissection, aortic rupture, or salvage surgery, because there's simply no point. There are relative contraindications, such as patients with poor ventricular function, aberrant coronary anatomy, extremely large aneurysms that you can't even put a cross clamp across. Some people may have 8 centimeter, 10 centimeter aneurysm. The full sternotomy, via the full sternotomy, sometimes all you can see is a big aneurysm. There is no point for mini-axis in those cases. Redo-cardiac procedures where there is extensive adhesions, and concomitant coronary artery bypass surgery, although you can bypass the right coronary artery via a mini-axis approach, and also concomitant valvular surgery other than aortic valve. These are relative contraindications in my practice for a mini-axis aortic procedure. But by and large, patients with isolated aortic aneurysmal surgery in the proximal ascending aorta, they will be considered for a mini-axis aortic replacement. So what do I look for on the preoperative CT scan? Well, everyone gets transthoracic echo. The CT aortogram, it is really important. It is really important that you assess the degree of arthromatous load and calcification, and think about what's the chances of stroke, and where you do the anastomosis is very important. I don't really mind the position of the ascending aorta. I know the surgeons make comments about the position of the ascending aorta to the right, to the middle, or to the left side of the sternum. And that is probably, that is the case for aortic valve replacement. However, when I talk about aortic aneurysmal surgery, the position of the ascending aorta doesn't really matter, because once you do the cross clamp, the aortic aneurysm will be excised. So it doesn't really matter the position of the ascending aorta in relationship to the sternum on the preoperative CT scan. However, I do pay particular attention on the proximal and a distal aorta where I'm going to do the anastomosis. Are there calcifications? Can I put a graft onto the aorta and stitch it back together safely? These are the things that are going through my mind. And also the coronary ostia, how calcified they are, where I'm going to cross-clamp, where I'm going to cannulate. So these are the important information that you have to consider in order to conduct this operation safely. Now, we developed these mini-axis aortic surgical instruments, as I touched on before. In particular, the mini-axis retractor, the heavy style needle holders, the single shaft needle holders, and knot pusher, and aortic retractor, of course, are important instruments in this set for safe conduct of this operation via a mini-sternotomy approach. For isolated aortic valve replacement, I've done, performed via mini-sternotomy with a 3.5 centimeter access incision. I started with 8, down to 7, down to 6 and 5 and 4 and 3.5. That's the smallest I went down to, but I now came back to 5 centimeters because it is not possible and inconvenient to perform through such a small incision, 3.5 centimeter incision for isolated aortic aneurysm operation. I think 5 centimeter access incision is quite comfortable. The key is to divide the sternal plate, as I said before, to the left side of the screen, to the left side of the sternum. Okay, not to the right. 99% of mini-sternotomy in my practice have a sternal division to the left side. The exposure is much better than to a right-sided hemisternotomy because you're actually lifting or spreading the minor plate away from you. That will expose the aortic annulus much more effectively, because when patients have aneurysms, ascending aortic aneurysm, the aorta tends to be pushed down and to the left. The annulus is more left-sided. So therefore, when you open a sternal plate to the left, you have much better exposure, especially around the right coronary annulus, expose the aortopulmonary window down the root level much more effectively. And also you can cannulate the distal ascending aorta and the proximal arch. The aortic cannulation site is right there in front of you. Once the aneurysm is resected, everything will be lying in front of you. And I do think that for people who haven't tried the left-sided sternal division, for routine aortic valve replacement, of course, as well, try the left side first. I rely on central arterial cannulation, femoral venous cannulation. Now, with this access incision, the 5 centimeter access provide a safe exposure for arterial cannulation, antegrade arterial cannulation, cross-clamp, and delivery of cardioplasia. Okay, I don't routinely use a retrograde. I don't use the right suprapulmonary vein vent. In the past, I used the pulmonary arterial vent, but I don't use that anymore because it causes more trouble, and I don't think it's necessary. But I will show you how we arrest the heart as myocardial protection in my following slide. So really, it is a minimalistic approach, trying to simplify it. Fewer holes and fewer holes for retrograde, suprapulmonary vein, and fewer pipes coming out of the main access incision, trying to keep the operation simple and clean. And that will allow you to expose everything. This approach that we've used is quite reproducible. But then you may say, when you open up the incision and heart is full and aorta is pulsating, and you can't see the root. Well, that is the case. You're not meant to see the root at this point of the operation. So don't panic and do this is what I call the double clamp technique, because you can't put your fingers around the ascending aorta because the incision is limited. Use the double clamp technique under low flow condition across clamp the aorta across in a safe manner. And once the heart is arrested, aneurysm is removed, you can see everything.
Please. Yeah, start on the root vein. Slow down all the way down. Yeah. With the slow down, we'll be able to get across the lead ascending with one cross clamp. With the other hand, so gently pull that down. Okay, with the other hand, you apply the cross clamp properly. You have to make sure all the way across. I can see the back wall on this side. I can see the back wall on that side, away from the pulmonary artery posteriorly. Cross clamp is applied. Okay, cross clamp is on.
So once the cross clamp is on under low flow condition, you open up the vent, aortic root vent, really empty out the aneurysm, empty out the heart, okay? And then flow back on and make sure the cross clamp, distal aortic cross clamp is in good position, not slipping away, and reestablish the body perfusion. So how do we protect the heart? Well, myocardial protection is the key. You can use a fibrillator to fibrillate the heart in patients with aortic regurgitation. But I'm going to show you this video where it's how we arrest the heart in pretty much all cases, even patients with aortic regurgitation, severe aortic regurgitation.
Okay, start hard on the vent. Okay, flow back up. Yeah, if you're happy with your flow, let me know. Okay. So now we have applied the cross clamp. This patient has moderate aortic regurgitation. Okay. Good, good. So what we're going to do is going to deliver a dose of antegrade catecholamine. So first of all, we're going to empty out the heart, empty out the aneurysm. Vent is off. Vent is off. Yeah, by sucking on the root vent, so we can see the ascending aortic flank. Okay, give a dose of antegrade custodial down the root. Okay. Control the pressure to about 80. Yes. So what happens is we're filling up an aortic root, ascending aortic aneurysm with custodial catecholamine. So with each heartbeat, the coronaries are perfused by the cataplegia solution. So that will allow the heart to slow down and fibrillate and achieve a diastolic standstill. Okay. And once the heart is arrested, we'll open up the aneurysm, and we're going to give direct osteocataplegia down to both left coronaries, left and right coronaries. Arrested? Okay, that's fine. Okay, we'll have a look at the pulmonary pressure. At the moment, pulmonary arterial pressure is about 5. Let me know if it goes up to about 10. Okay. And you just drop the perfusion pressure to about 60. Okay, we don't want to distend the ventricle with aortic regurg, but we're just going to deliver the cataplegia very slowly. It is custodial, so its duration of the cataplegia delivery is very important. Topical code as well, please. At this point, I'm going to give some topical code. Just pulling down the surface of the heart. Now this is to the left. Okay, good. All right. Let's give 70% to the left, and we're going to give to the right later. Okay. So this is how we arrest the heart when patient has aortic regurgitation in a mini access. I don't routinely use a right superior pulmonary vent, and I don't use a retrograde cataplegia delivery system because I don't like to make too many holes in the heart, all sorts of bleeding. But we'll be able to achieve good diastolic arrest with this method.
So as I showed in this video, initially you have to empty out the heart, empty out the aneurysm, completely make sure the ascending aorta is flat, and then deliver the initial induction dose of custodial cataplegia down to the aortic root. And obviously in patients with severe aortic regurgitation, that cataplegia will go into the ventricle. Okay, but with the heartbeat, each contraction of the heartbeat, that will the cataplegia is now going to be ejected into the coronary, and then eventually the heart will fibrillate and arrest. and don't fill up the ventricle quickly and under high pressure. Just allow the heart to slow down, to arrest. And once the heart is rested, open up and excise the aneurysm and give a dose of antegrade cardioplegia via the ostia. So that's how we arrest the heart, and we haven't had any issues with myocardial protection, and it's quite simple, and you don't have to have additional cannulas and the lines coming through the main incision. Now, this is called the crane maneuver. It is a very simple and effective way exposing the aortic annulus. And at the beginning, you can't see the aortic root and aortic annulus because of the aneurysm. But once you excise the aneurysm, the bigger the aneurysm, the easier the operation is for you, actually. Because once the aneurysm is removed, there is a lot of room, mobility you can play with, and you can actually deliver the aortic annulus almost to the level of the skin. Okay, so the aneurysm obviously formed over time. It pushes the aortic annulus. The aortic aneurysm pushes the aortic annulus down and more towards the left side. But once that is excised, the annulus can be brought forward, and you can really enjoy the mini-access surgery.
So now we have excised the aortic root aneurysm and mobilized the coronary button. Now we placed 3 sutures, traction sutures, above each of the commissures. As you can see, when the sutures are relaxed, that's where the aortic annulus position is. Because of the aneurysm, it really pushed the annulus down and pushed the heart to the left. So this is why sometimes on a pre-operative CT scan, the annulus is at the xiphoid level. But once the aneurysm is resected, you can do this what's called crane maneuver, by lifting up. It's really lifting up the commissures. And here is the position you'll get with just some traction, not too hard. But you can see the aneurysm, once it's removed, you can deliver the annulus very high up. So what is comfortable at maybe around 5 centimeters from the skin edge, it's pretty comfortable to do a root replacement. The button is mobilized, and the annulus is right here. And so we're just going to do a French cuff technique for this patient. But it's good exposure, whereas before you couldn't even see the annulus, and now the annulus is quite well visualized. The bigger the aneurysm, more mobilization you will have, more anteriorization of the annulus you can do. So this is quite comfortable. Otherwise, you can pull up the harder as well. Anyway, okay, can I have the valve organizer, please?
So as you can see from this exposure, you can deliver the annulus all the way to the level of the surgical incision. And I use this pediatric drop vent through the aortic annulus during the case. And you can see the main sternal retractor, that is, it's positioned very nicely, is flat to the surface of the skin. It doesn't tilt because it's got a texture surface and really have a very good grip on either side of the sternum. And also we don't have that handle. Sometimes the Cash's sutures annoys you immensely during the operation, because every suture the nurses pass to you that catches on the handle of the retractor. So all of that is simplified with this set of instruments, and you can see the exposure is excellent for doing a root replacement. So this is what I call the French cuff technique. I use a Valsalva graft and I folded the skirted portion outside and over the Valsalva portion of the graft to form a double cuff, hence the name French cuff. The initial annular sutures, you place the annular sutures the normal way, the needle is passed through the sewing ring of the valve and also through the folded edge of the Valsalva graft. And the whole valve and conduit now is passed down to the annulus, and you tie the sutures around circumferentially. And that is the first layer of an annular suture layer of root implantation. And then you do what I call the second layer, which is the hemostatic layer that incorporates the remnant of the aortic wall and also the everted cuff edge. So there's a 3/0 or 4/0 running proline suture that goes around the aortic root. Once again, extra 15 minutes spent here is worthwhile because it's absolutely hemostatic. Once the cross clamp comes off, there's no way you can see these annulus again. So make sure, now is the time to make sure it is absolutely hemostatic. And the extra 15 minutes will save you stress, save you time, and also save your products. Anastomose the coronary buttons and do the left side first and the right side. Be careful with the right coronary button, especially when the right coronary is vestigial, very small. Make sure the button is not twisted, orientation is correct, and position is correct. The right side, I fill up the heart to check the position before I implant the coronary button. This is our initial publication of mini-bento procedure, French cuff technique. You can also do mini-access David procedure via the same incision. Use a ball tip, 3 millimeter ball tip to mobilize the aortic root, soft tissue outside the aortic root, and then perform a David procedure because the exposure, once again, is right down there, and you can access pretty much everything you can see. You can see from the main incision. I don't have a vent, no retrograde. All I have is a distal ascending aortic cannula and also the cross clamp. Now, you do the subannular sutures and also suspend the commissures the normal way and check the valve competency and make sure you're creating that neo-sinus in a U shape rather than a V. Bear in mind, you have to put the coronary buttons in position, so that sinus has to be a U in shape rather than a very narrow sinus to allow a very competent valve towards the end of the case. And do the coronary button reimplantation. And in this particular case, because of downsize the intercommissural distance, it induced a little bit of prolapse. So that's why we adjusted the effective height of the coronary cusp to about 9 millimeters. So the valve is competent towards the end, and you can do a David procedure via the mini-access incision. What about a distal aortic anastomosis? I use a double layer technique. Okay, the first layer, starting from the back wall, furthest away from you, forehand running proline suture towards yourself. And once the back wall is finished, stop there. You do a second layer, either another layer of running proline suture, or if the tissue quality is not very good, you can use the interrupted 4/0 or 3/0 plated sutures with the platelets on the inside. Okay, so this is the plated sutures in the back wall. You don't need to worry about the platelets because yes, it's on the inside. But when you do a valve replacement, the platelet is on the inside of the blood flow anyway. So it doesn't cause additional risk of embolization as long as you secure these platelets, okay? Make sure the sutures are locked and plicate the back wall now, because if bleeding from the back wall once the cross clamp is taken off, it's very hard to fix. So take all the precautions, do all the necessary steps now, the repair sutures and whatnot. If you think there's a dog here, fix it now. Do it now or never, because you won't be able to see it again. It's all about your planning and then how you make sure the whole procedure hemostatic. So beyond the aortic root, you can do a mitral valve procedure with the incision through the roof of the left atrium, the superior approach. So this is pulling back the commissure between the lung and left forward, and then you can, through the roof of the left atrium, you can expose the mitral valve. You can access the mitral valve from the roof, and also you can access the mitral valve, especially the anterior mitral valve leaflet, through the aortic annulus. When the aneurysm is removed, you really have a lot of room to play there. And also we do a proximal aortic arch procedure through this approach with moderate hypothermia. I do that down to 25 degrees with selective anterior cerebral perfusion via direct cannulation into the innominate artery. Okay, but be careful with a degree of arthromatous load around the base of the head and neck vessels. Make sure when you do this there is no risk of embolization or dislodge the calcium or atheromatous debris. Otherwise, you do the by the right anterior, do it by the axillary artery cannulation. Keep it simple and safe, and make the whole operation easy. I think that's the philosophy of doing these procedures. You can also do the aortic arch, a frozen elephant trunk procedure via mini-axis approach. But I think the key points are management of the left subclavian artery and also the management of distal aortic anastomosis. If you can make sure these two anastomoses are tight and secure, hemostatic, artery replacement procedure is not difficult. So how do we manage the left subclavian artery? And obviously, you can use direct reimplantation with a trifurcated graft, debranching the head and neck vessels like George Matallanes' technique, the branch first artery replacement, which I think is very handy because you get the head and neck vessels out of the way. But for patients with the left subclavian deep down in the chest, you can use debranching, extra anatomical bypass, and left subclavian carotid artery bypass. And this not only applies to mini-axis, but also applies to routine cases. Don't stress in trying to stitch in a deep, dark hole. Think about other approaches, whether you can do an extra anatomical bypass with the left axillary artery, drop a graft to the left chest, and bring up through the mediastinum, attached to the ascending aorta. And also the vascular tech to Rumo is now coming out with this French cuff custom hybrid graft, where you put a little stent into the left subclavian artery and with a simple stitch and secure and perform that anastomosis in a hemostatic manner. Now, in terms of the distal arch anastomosis, trying to bring it forward to zone 2, anteriorize the distal anastomosis, safer and easier access, and also reduce the risk of recurrent laryngeal nerve injury. In the issue of annals cardiothoracic surgery recently, we explored the techniques of frozen elephant trunk in this entire issue, and feel free to have a look at that. This is a patient with distal arch aneurysm.
It's on the right-hand side. Has an aneurysm in there. So we need to make sure we're going down to the true lumen there, not into the aneurysm with elephant trunk, frozen elephant trunk. Okay? So that has to travel down the direction of the sacrum. Okay? We'll do that. So this one has to face anteriorly. Take out the vent. This is actually sent out. Okay, imagine. Okay. Pull out that. Now hold the graft down and then wiggle until the whole thing comes up. Here's the common carotid going through anastomosis, and the graft is deployed. Graft is deployed in the distal arch. Anastomosis is going to be here. Okay. And I will do anastomosis like that. This is the traction suture holding the aortic arch. Okay. So completely excluded the aneurysm and also the penetrating ulcer. proximal anastomosis. This is anastomosis, the trifurcated graph. If I lift it around, that's the innominate artery. Okay, and I'm going to gently rotate this scope up. Yeah. Here is the anti-flow thoracic trunk, or thoraflex, thoraflex hypergraph. Distal anastomosis.
As you can see, this the root ascending proximal arch or distal arch operations are supracardiac procedures. That's why you don't need to see much of the heart as long as the myocardial protection is done correctly and safely. Now, for patients with arch aneurysms, it's much easier if you select the patients who have distal arch aneurysm, because distal arch aneurysm may push the aortic arch, proximal arch more towards the operator, towards yourself. You have a head and neck vessels that's more anteriorized, rather than patients having a mid-arch aneurysm that everything is pushed away from you. So select the patients with distal arch aneurysm, and then I think that they are suitable cases. They are suitable cases. You look for them for a mini-access procedure. The frozen elephant trunk is actually quite an easy device to deploy with the Thoraflex, because it all takes 3 simple steps and add additional probably 5 minutes to remove the strap, remove the splitter, pull the pin out, and then remove the handle, and then do the zone 2 arch anastomosis right there in front of you. I debranch the head and neck vessels with the trifurcated graft at the beginning while we're cooling. And then once we're cooled, we do the distal anastomosis. So that's how we perform the frozen elephant trunk. And I am selective, and I think about if I can do the subclavian artery anastomosis and the zone 2 arch anastomosis safely in these cases before I take them on as mini-access. So we've done overall more than 150 cases of proximal aortic procedures. 70% of these patients had a root operation, either a valve-sparing root or bento procedure. And there's about 65% of patients had arch procedure, proximal arch and total arch operation. These are our initial results. And we're very meticulous and take every single case seriously and look after our patients. So our results are quite acceptable with this mini-access surgical program we're running. Once again, we do have the cadaver course, and Martin comes from Germany to facilitate the cadaver course here in Sydney, and hopefully we'll resume this from next year again. Once again, thank you for the opportunity to present, and I can take some questions.
Thank you, Tristan. It was an excellent demonstration of your mini-aortic technique, and yeah, we are ready for some questions. So let me start with, again, focusing on your cannulation strategy. So you have a central arterial cannulation and peripheral venous cannulation. Is it venous cannulation percutaneously, or is it open? And in which cases do you also perform distal arterial cannulation?
Okay, so yes, central arterial cannulation, because I'm an aortic surgeon, I like antegrade perfusion. If there is any concerns about degree of atheromatous load, calcification, and also problems with the descending abdominal aorta, I prefer to have antegrade arterial cannulation. And that is with the cannula in the distal ascending or proximal arch, and then that cannulation site will be excised if we're doing a hemi-arch replacement anyway. So keep the cannula straightforward and right there in front of you via the same axis. Now, femoral venous cannulation. If I only do the femoral venous cannulation without the arterial or peripheral arterial cannulation, the femoral venous cannulation will be done via a percutaneous technique. If I do the arterial cannulation as well via femoral vessels, and that will be done as a cut down. Okay, because I like to put purse strings around the femoral arteries as well as the femoral veins when I do a cut down to make sure that there is no distal perfusion issues and there's no pseudoaneurysms. No, repair the vessel if it is necessary. But if it's only isolated femoral venous cannulation, I'll use a percutaneous technique. I rely on my anesthetist to, I know you do the ultrasound yourself or some, puncture the veins, but I get my anesthetist to put in that little sheath in a femoral vein at the beginning of the case. And then all I need to do at the time to thread through the sheath and get on with it. So and then towards the end of the case, I put a purse string around the skin where the femoral venous cannula is, and then just pull out the femoral venous cannula, tie the purse string, and that would be the way I do the femoral venous cannulation.
Okay. You showed us the advantage of this special design retractor, and in my experience, it's really an issue if you use a conventional sternal retractor that it really tilts. So this one doesn't tilt at all. So it's very nice to use, and I use it myself as well. It's a great retractor. So one more question regarding our redo cases. Do you perform partial upper sternotomy also in your redo cases?
No. No, I don't do that because I like to have absolute control. If I don't have that control or rely on possibly or probably I can do it, that's not my way of approaching it. I know that there are surgeons doing a redo operation via a partial sternotomy. The skin incision is already there. You can't make a more minimally invasive than, I think it just makes the operations more complicated. So in my practice, now I don't do redo cases via mini-sternotomy or hemi-sternotomy. But you're right with the sternal retractor, it doesn't tilt. It just sits there flat. But sometimes when you use the retractor, for some reason, you use, previously we had the retractors, you have to bend over the table to see the aorta because the retractor tilts away from you. So that can be quite painful.
A bit advanced in time, but one important question which always comes up is with regard to training and education. And in the questions we send out and the answers, what are the most difficult steps to begin minimally invasive aortic valve surgery? The participants answered that the cannulation technique is the most difficult step. These were 70%, but mainly almost half of all the answers were that exposure of the target. So as you underline, exposure of the target is the most critical part, but also using instruments was for some an issue. So what would be your advice for a surgeon, a young surgeon, or even an experienced surgeon, how to start performing mini-invasive access surgery?
Well, just touch on the point you made about the cannulation. Trying to keep it in a routine fashion. If you routinely cannulate the distal ascending aorta, don't change that just because we're changing the axis. Every time we change a little, change one element of your operation, not whole elements of all your operation, and you'll be thrown out of the, out of your comfort zone. So change one aspect. If this time is the axis, maintain your routine cannulation, especially the arterial cannulation. Make sure the exposure you have, you can see the distal ascending aortic cannula, where you're going to put purse strings and safely to cannulate. Because as I showed in one of my videos, that axis allows you to cannulate, cross-clamp, and deliver cardioplegia. The exposure of the annulus of the root only happens once you excise the aneurysm. And exposure is super easy. You actually bring the root upwards. So that's the key point with the cannulation, because that is the dangerous part, is how you cannulate, whether you can control the cannulation side. It's not how you exposure, because once the aneurysm is removed, you can expose it. Now, I would say you need to make sure that you can safely perform aortic root aneurysmal surgery, ascending aortic surgery without bleeding under usual circumstances before trying a mini-access operation. And when you can safely and reproducibly do these root operations without bleeding, and then you can minimize the incision, even through a full sternotomy, and then try the partial sternotomy, and you may need the exposure for about 8 centimeters skin incision, that's okay. come down gradually with each case. It doesn't happen overnight for me. So come down gradually, and each case, think about if you can do something slightly different, slightly better than the case before. And with time, and then you will have your comfort zone and everyone working with you, professional institutes will work with you and develop that team, the sense of progress together. And then you'll realize maybe the surgeon may realize in a year or two, your practice is different from a year ago and from 5 years ago. So that is the philosophy we use, is if there is something, even a tiny little thing, we can do slightly different, slightly better than the case before. We would talk about do a debriefing session with my team on a regular basis. We explore that and make sure our improvement is incremental, only a small amount. But I think it is important. A year down the track, you will realize the progress you have made together as a team.
Finally, what is the value of a cadaver course or wet lab course and getting a proctor?
I think that we need to have a good simulation model, and I think that the cadaver course is the best model to learn, to achieve, to feel comfortable with the instruments for the exposure. I find a lot of times there is the point I touched on before, there is that mental barrier of moving away from your comfort zone. Okay, but I do think the cadaver course offers the surgeons and trainees the opportunity to get across that barrier, to see where the valve is, how good the exposure is, and how to expose, and through the mini access incision. And I think that's the way. I think in the future, it's going to be that having regular cadaver courses that we run in Sydney, and it's very important to have someone like you, Martin, to come to facilitate such a course, because you're expert in doing not only mini aortic and mini mitral procedures. And we're very fortunate to have you here and join us in Sydney. But due to COVID, of course, we can't do that this year. I'd just like to thank Delacroix and also the team led by the CEO, Benoit. Thibault and I, we have been working together over probably about 8 years now, developing this set of instruments. As you can see, they're very simple instruments, nothing fancy about that, but it does allow surgeons to perform the operation safely and effectively. I'm sure there are many surgeons with brilliant ideas, and I really encourage them to come forward and to work with Delacroix, because I think their working ethics is fantastic and very helpful. Thank you, Thibault, for organizing this event as well.
Thank you, Tristan, for sharing your experience with us. And I would like to hand over to Thibault for some final words.
Yeah, thank you, Professor Jan. Thank you, Professor Misfeld, for this very rich and insightful session. The exposure of the target you've shown is amazing when we compare to the size of your incision. The tips and tricks you've shared are really important to get this kind of result, especially dealing with the most complex procedures, which include MEH replacement, for example. Professor Misfeld, we appreciate your accurate questions coming from both the audience and from your own expertise in this surgery. I mainly think about your question and remarks coming from the registration process. I think it's really important to know what are the main difficulties we are going to meet when we start a minimally invasive surgery program. And it's obviously crucial that expert centers like yours provide the key steps to succeed. A big thank you also to all the attendees for your relevant questions and remarks in the chat. We had over 200 people connected. I hope it has been beneficial to each and all of you. Delacroix-Chevalier is committed to promote minimally invasive cardiac surgery solutions, and I'm glad to announce that another surgical lecture will be scheduled soon. Thank you again, Professor Jan, Professor Misfeld. Thanks again for attending this event. Stay safe and see you again soon, virtually or physically. Have a nice day. Goodbye.
You too. Thank you.
Bye-bye. Bye-bye.